Good afternoon. It's a pleasure to be here. I've been watching these lights here, and I just wondered what happened after that red light flashed for a while, and I will try to avoid that so that we can stay on track. I am from the insurance industry, and I will readily admit that I will bias my comments in that regard, but I think my colleagues on this panel will help pick up the slack. I will point out that both in terms of insurance versus hospitals versus clinics, it takes a village to treat things, and I would actually extend that out well beyond the healthcare arena. With regard to our progress and our industry's progress as it relates to obesity, I think there are four key areas. The first is health benefits related to the treatment of obesity, particularly in the healthcare setting. We have seen, we in North Carolina have offered benefits for physician assessment and referral and treatment of obesity for about 10 years. We've offered nutritional counseling at no cost for the same period of time. And then have offered a number of health programs. I think what's been particularly helpful has been the synergies that we've been able to create with work sites between the health benefit plans and the workplaces. While we offer some benefits, it's really the work site that can help direct folks to using some of the medical benefits that are available to them. In that regard, I will make a comment that the Affordable Care Act, one, is important. It is the law of the land, so let me just make that clear from an insurer's standpoint. But it does, in its well-intended non-discrimination perspectives, has limited some of the levers that we have in terms of inducing behaviors, and I'll speak to that a little bit more later. The second part second area of progress is in health programs. Here, I think we've had a number of providers, hospitals, clinics, primary care physicians have, we see models, and particularly individual models of folks that really do a great job of working with particularly severely obese folks. I would say that that's still fairly sporadic, and it also tends to be pretty expensive. With regard to the other area that we've seen good progress, and again, particularly as it relates to severe obesity, is in bariatric surgery. We got into working with bariatric centers of excellence, again, almost 10 years ago, because the complication rates were so high, and have worked collaboratively with providers to really come up with programs that are far better. Community impact is another area. The insurance industry, through its foundations, has funded a number of activities in North Carolina. We've helped fund the farm to school programs. We've also funded curricula for for daycare workers around nutrition. We've funded a number of physical activities. The picture here is a bicycle commuting program that we set up in Charlotte, North Carolina, and in some other communities. So a number of programs there to help out. And then thought leadership. I think one of the things that we have found, particularly within the payer community, is an inordinate concern about upfront expense. And one of the areas that we've been able to show with some of the publication of the results that we've done is that it actually isn't that expensive to provide benefits for treatment of obesity. I have, in our own look at our nutrition benefit, while we offer six visits a year at no cost, the average number of visits is about 2. And we will not go broke for 2 nutrition visits a year. It is not a service of abuse. Now, with regard to what are the potential areas for breakthroughs to fight obesity, I've chosen 5. The first is provider education, training, and teamwork, and I'll speak to that a little bit more in a second. The second is around patient engagement, I apologize almost for using the term patient. It really ought to be member or consumer, because we don't need to medicalize obesity as a condition in all cases. So patient engagement and activation. The third is making sure that we address obesity throughout life, whether it's breastfeeding, daycare, working, whether it's prevention and maintenance, on through to the full treatment of obesity once it gets there. The fourth is safe environments for physical activity, which is, again, is as much a social determinant of health as it is a medical one. And finally, offering better nutrition choices, which we've already heard about. My two focus areas are, one, provider education, training, and teamwork. I wanted to make a specific point that the P in provider is not a typo. It is a small p. Being a provider is not the sole province of physicians, nor even nurses or nutritionists or pharmacists. Parents are providers, grandparents are providers, pharmacists are providers, preachers and priests are providers, even politicians and policymakers are providers. And we need to be working on the education, the knowledge, and then the teamwork around this. Where we have folks who do understand what needs to be done for obesity, we don't seem to play that well together. They tend to be isolated pieces. So the schools are not talking to the daycares, they're not talking to the parents, they're not talking to the health plans, the insurance plans are not talking to the public health departments, and this needs to be a team effort if we're really going to get this done. Again, much like Bill commented earlier, in smoking, that was as much a social effort as it was a medical effort, and it certainly wasn't one small segment. The second piece is around patient engagement. And we've heard this mentioned several times, or patient activation. I think particularly we in the insurance industry tend to think about things in terms of incentives and money. Obesity is a complex behavior. Developing healthy habits is a complex process, and simple money won't do it. Simple knowledge won't do it. And we really do need to begin to think through other models of how we're going to help folks develop healthy habits. Behavioral economics offers a great deal of promise in this regard, but my experience with that to date is that it really more explains current irrational behaviors, to quote Dan Ariely, but it doesn't tell us what to do about it. So I think we've got a real opportunity to spend a good bit of time figuring out how to learn the lessons from behavioral economics or other models of habit behavior change, and then to apply it for outcomes. So with that, let me stop.